Hello and welcome to the Complete Health Podcast, the podcast that brings you a complete view of healthcare, exercise as medicine, and much more.
We're your hosts, Helen O'Leary and Reece Noble, both physiotherapists at Complete Physio and Pilates in London.
This is episode 10, the fourth and final part of our chat where we sit down with pelvic health specialist Clare Pacey to talk about the postnatal period and how you can return to exercise safely.
In this episode with Clare, we're going to look at common postnatal related musculoskeletal conditions and what you can look out for when returning to training. She also looks at the evidence base behind returning to running and how you can safely get back to the activity that you love.
Hello and welcome to episode number 10 of the Complete Health Podcast. I am here with my co-host as always, Helen O'Leary.
Hello.
Lovely to be with you as always, Helen. And we have our wonderful guest today, pelvic health physiotherapist Clare Pacey. Thank you again for being here, Clare.
Hello.
Excellent. So a few of you may have already listened to our first 3 installments with Clare, where we've been through everything from what a pelvic and women's health physio does, and we've also then gone into the stages of pregnancy and giving birth. So installment number 4 with Clare today, we're going to talk about postpartum or after birth, and the important things that women need to know post-birth, what they can potentially expect, and the ways a pelvic health physio can help during that obviously really hectic but special time. So really looking forward to this as always, Clare. So thank you.
So I'm going to kick this one off with asking about probably the thing that lots of women know about and don't necessarily know what happens during the 6-week check.
Absolutely.
This magic 6 weeks.
So, yeah, exactly. When everything's fine. So the standard care, I suppose, in the UK is that you have a GP 6-week check, which, GPs, I think they probably have 10 minutes for this check. Mm-hmm. So they have to prioritise, and their main focus will be to highlight any really big issues that they need to refer for, and also mental health issues. So has this woman got psychosis or post-traumatic stress disorder or postnatal depression? So that will be the focus, and then the focus will also be to talk about contraception.
Interesting.
And most women are thinking that there's no way I'm having sex right now anyway, so it's not a problem. But and that you will get some GPs who have a specialist interest within women's health, and so they might go into a bit more. But you're a GP; they can't know everything. They know a lot about a lot. But I think we need to have the right expectations of what that check is.
So there's no guarantee that they will do a physical assessment on you?
No. So postpartum, initially you have a midwife come out to your house to check stitches and things like that, and then you'll have your 6-week GP check. And if you've gone privately, you'll have a 6-week check with your consultant. And that's it. And it's not enough, and it's not good enough, but we also have limited resources and money and funding and all the rest of it. And so I really think we need to reframe it, and we have to hope that the NHS, the amazing NHS, will pick up the most vulnerable people who can't afford to go elsewhere. But for those of us who can, we have to start reframing it and reconsidering it. And I've recently had some men buy their wives some sessions with me, which is brilliant. I love it because, so stop this, pushing present, give them rehab, because that's what they need. They don't need a ring. They need a physio session and some Pilates and some rehab. So I definitely think there's a place for just owning it a bit more. And, we most women, I know not everyone, but most women get their hair done, they get haircuts, they might get their nails done, they have a mobile phone, they buy clothes, they spend money on meals out. This is just another thing that is so important, and I really think it's worth prioritising, because, like I said, previous episodes, it can completely change your trajectory for the next 20 to 30 years if you just give yourself the rehab it needs. Your body's been through so much, and you need to rebuild a foundation. And if you miss out the beginning bit, the fallout can come later on, and athletes have to rehab. It's not something you can skip.
I think that's so, for me, I've had conversations with more expecting mothers about reframe this as a sports injury.
Absolutely.
Yeah,
That's how I treat it.
Yeah,
Exactly.
If you've done your ACL or you've pulled your hamstring, you have dedicated rehab for it.
Yeah.
And if anything, being pregnant and giving birth is harder on the body than many of those injuries.
Absolutely.
Really long.
Way
It's the
harder.
longest endurance thing you can do.
Yeah.
Way harder,
So you
yeah.
reframe it as that and see your physio as the best chance of you to get back to whether it's sport or whether it's just general life or think of it in that regard.
Yeah, and I think it's really important as well. So there's no guarantee that you're going to have a 6-week check. So I know some of the boroughs in London have actually stopped a 6-week check for
Because of
GP because
COVID.
of resources, because of COVID at
And
the moment.
telephone consults
And so
instead,
they're doing, so there's no guarantee that you're going to see your GP. So I think, if you have any concerns postnatally and you fall into that category of your GP service isn't doing a 6-week in-person check or something like that, and you're concerned, then you need to ask for it.
Absolutely. And, I worked for a decade as a pelvic health physio in the NHS. It exists. There are amazing physios working in the NHS. So, if you don't want to pay privately, then get a referral from your GP. And yes, there'll be longer wait times, but that's your choice. You either pay privately and you see someone quicker, or you get on the waiting list to see someone in the NHS. And so they're your options, really.
And I think a lot of people will obviously compare us to France or
Yes.
Scandinavia, and obviously in France there's a big thing about there's a certain amount of post-birth sessions that you can get as a woman for yourself to do rehab. Same in Scandinavia. So do you want to talk about those and what they might involve?
Yeah, and that's amazing. And because of that, so there's quite a lot of obviously French women in London, and French women will seek me out. And they'll often be the ones that turn up and say, my birth was great, everything's fine, where's my physio? They expect it because in their country it's part and parcel. You have rehab, which makes complete sense. So they expect it and they seek it out. And I think because it doesn't exist in that capacity in the same way in the UK, we just think, it can't be that important then. And that's just not the case. The only thing with the French system, however, is that because it is a government-funded system, I'm sure there's limitations on it, but it does become mostly about doing pelvic floor exercises, which is extremely important. There's incredible evidence for doing your Kegel exercises, and I'll come on to that in a moment, kind of how to do it, and how often, all the rest of it. And we have evidence that, that is super important, but it's not the full rehab picture. I mean, I wouldn't be so obsessed with my job if I just gave people pelvic floor exercises and that was all.
Boring, wouldn't it?
I think I'd be a bit bored. So they are so important. So they're very good at doing that element, but I'm not sure. It may have changed, but from French ladies I have seen, that's what it's mostly been about. And there is a lot more to rehab than the pelvic floor exercises, although they are a brilliant starting point and very important.
Sorry, I've just lost my train of thought there. So actually, that's what I was thinking about. Just out of interest, you mentioned obviously paying privately.
Yes.
How much does a session with you cost?
So at Complete, it's 150 for the initial consult, which will be around an hour. And following that, I send people a report with the findings. So their vaginal examination assessment, their abdominal assessment, and all my recommendations, and normally some exercise videos that are bespoke to them. And for some people, they will say to me very clearly, I'm just having one session, and so I will make sure that I teach them the strategies they need and go over everything, and then I might hand over to a personal trainer or a Pilates instructor or someone else they're seeing, and kind of link in that way. And other people, I think it's quite difficult to sometimes get everything across in one session, and some people need more support. So follow-ups are then £75 for the 30 minutes. So that's in the Chelsea clinic.
Yep.
Yeah.
And
Or Zoom.
If you come with very clear expectations and you know what you want, I always say this, whether you're going to see a consultant or a physio or whatever, write a whole load of questions down, because the minute you get in front of someone, inevitably your mind goes blank and you can't remember what you were going to ask or the problems that you've been having unless they're major. So write questions down, even send them in advance, and actually that means that you're probably going to get a whole load more out of your session than you would do if you're trying to remember things when you're in front of someone.
Yeah.
And it's it's a small investment for having good pelvic health for the next 30 or 40 years, isn't it?
It really is.
Yeah.
I don't think I've never had anyone regret, spending their like, oh my gosh, this is amazing. I didn't really know what to expect, but I'm so glad I've done this. Because even if it's just brilliant news, even if it's just, actually, you've got no diastasis, your pelvic floor is fantastic, crack on, keep going. Like, that's really good to hear, and it's nice to know.
Yeah.
And so people are always keen. And the first thing I always ask when someone comes in is, what are your goals? What do you want to achieve? So it's always very tailored to the individual. And yeah, I think people are always happy to spend the money. And with COVID, I moved to Zoom and can't quite believe I didn't do it before, to be honest now. And so I am still doing remote consults. And although I love to assess someone initially in person because I like to take the baseline measures and I know exactly what I'm working with, partly because there's not any correlation often between what someone's symptoms are and the actual structural changes. So for example, with prolapse, with pelvic organ prolapse, someone may feel their symptoms are really bad, but actually it's only very mild. So I like to take baseline measures initially, but then I can follow up over Zoom, and that makes it much more affordable. So a Zoom follow-up is much cheaper, and you can progress people really well and coach them really well in that format.
Moving forward.
Yeah.
So what are the most common kind of postnatal things that you see?
So I would say it's got to be incontinence, urinary incontinence is a big one.
So it's normal to have urinary incontinence.
It's common, not normal.
But in saying that,
it's common.
It's not normal to continue to live with it. There are things you can do to help it.
It's treatable. Yes, it's not a case of managing and putting up with. It's all treatable. Yeah. Pelvic floor exercises and physio has so much evidence for it. Yeah. Like so much. It's 70% of people have full resolution, 90% get a lot better. I mean, the stats are good. It's better than surgery, the stats.
This shows you that if you do have that little bit of leaking and you ask your girlfriends who have had babies too and they have it too, although there's a lot of people with it, because I think you said in previous episodes 1 in 3 women have it doesn't have to stay.
No, and I think because other people have it, you think, oh, okay, then.
It's fine. Yeah.
It's a bit like, when you return to sex after having a baby, the stats are that at 12 weeks postpartum, 60% of you will feel discomfort with sex, pain with sex. And I'm not saying that to make you worry about it, but more just that, okay, that's quite common, but we would expect it to eventually feel completely comfortable again. So if it doesn't, and I think it's easy to almost just accept, you almost don't realise it's a bit uncomfortable. You just kind of think, oh, this is just how it is. And you forget that it didn't used to feel like that. But things should return to normal. So yeah, the most common things would be pain with sex, incontinence, mostly from the bladder, or it could be fecal urgency, poor control of wind is very common, and prolapse are probably the biggest things. And then there's diastasis. So they're probably the most common things I see postpartum.
So diastasis, obviously, this gets a lot of press.
Yes.
And I've heard lots of people explain it as a tear in your abdominals. So obviously that's actually not what happens. Do you want to talk about what it actually is and how you can recognise it, what you can do to change it, if it is changeable?
Yeah, absolutely. So diastasis of the rectus abdominis muscles it's a real hot topic at the moment, and I think as a result of that there's lots of miscommunication, but ultimately it's where you've got these two big muscles that come down the front of your abdominal wall in the centre called the rectus abdominis, and they're attached by a thin tissue called the linea alba, which is a small connective tissue, a bit like a cling film. And during pregnancy, that cling film tissue will soften and start to stretch, and it will allow the muscles to come apart to allow you to grow your baby. So by the 3rd trimester, this will be there in 100% of people. And I am getting more and more women coming to me and saying, I need to book an appointment because I've been told I've got diastasis and I'm really worried.
Yes, you do. Yeah.
And I'm like, yes, you do. You're pregnant. It's normal. So it's normal. You have to have it. It's fine. And currently, there isn't loads of research on it, but currently we don't know why some people remain abnormally wide postpartum and some don't. It seems to be a genetic lottery. There is a little bit of evidence that showed that if you exercise your abdominals kind of appropriately during pregnancy, you've got better results after. But again, once you kind of pick that research apart, it's not overly robust. So really, it does seem to be a genetic lottery. It doesn't seem to be correlated with kind of skin type or size of baby or anything like this, actually. So, you know, I hope that's reassuring. If you do have a diastasis, it's just how it is. That's the draw you've got dealt, and let's try and do what we can to improve things. So postpartum, I wouldn't really worry before the 8-week mark. So the research shows that by 8 weeks, what your abdomen kind of from a diastasis point of view is like at 8 weeks will be the same at a year if you do nothing. So kind of the initial recovery is happening. Yeah. So, but if at 8 weeks you're thinking, oh, I still feel that my midline feels very soft and there's not a lot of tension there. So when you put your hands into the kind of belly button area and all the way up and down, it feels very soft and like you're sinking in. So there's not much tension, and you feel like there's quite a wide gap. So the distance between the two rectus muscles is quite wide, then it's probably a good time to see a physio. So, but with that, I need to be clear that everyone has a gap. Yeah. So I haven't had a baby, and I have probably 1 to 2 centimetre gap between mine.
1.5 centimetre.
Yeah. So that's normal. That allows you to breathe. It allows you to eat a big meal. Men have a gap. Everyone has a gap. So anywhere between 1 to 3 centimetres is considered kind of normal. But it's not all about the gap. I do take measurements of the gap. I personally measure at rest because that gives me more important information than when someone does a head lift. And I'm looking for all sorts of things, but I'm more interested in the tension and I'm interested in function. So you may have someone who has, say, a 10 centimetre gap of their muscles at rest, but their tension is quite good. They're not doing I call it the Toblerone effect. They're not doming a lot in the middle. They're able to manage their pressure. So when I get them lifting and squatting and moving, they're able to generate tension within that tissue. So that's great. Or I might get someone who's got a much smaller gap, but they can't control it as well. So it's not just about taking this one measurement. But I think if you feel you are abnormally wide and you feel it feels very soft and you're getting lots of that central doming, then that would be a good time to have an assessment with a physio. And treatment-wise, obviously it depends. There is no protocol as yet. With more research, there may be in the future. But the common theme across all the research is definitely that strengthening, basically start loading it, start stressing it.
So obviously we see a lot of people with diastasis in the studio, and what we tend to do is train a little bit more specifically at the beginning, so people will be able to generate that tension that you talk about in different positions. It might be a plank position, so on all fours and a plank. It might be in side lying work in like a side plank. It might be in a sit-up type position, and everyone is different. But if you can find that position where you naturally can close it and not close but create that tension, then that's where you start training someone and then dropping in other kind of positions. So I think it's really important to make sure that from an exercise perspective, if you are going to see a PT, if you are going to see a Pilates instructor, that you know when you can create that tension the most optimally and train specifically there until you get kind of a better result in the other positions. So it's this constant assessment.
Yeah, I agree. And I think there's 2 things that are banded around. One is people are told, oh, you've got a diastasis, so that's fine, just don't do planks and don't do sit-ups. And there is no good or bad exercise ever. There is no one exercise that's going to fix you, whatever fixing means anyway, but it's a combination of different exercises, and it's always you assessing your ability to perform an exercise. So you might have someone that they can't do sit-ups because they come into a really hardened dome and they can't manage their pressure and they are getting a hard doming, but you might get someone else that can do that. So it just depends. And my general guidance is if you're doing an exercise and again you're having to breath hold or brace your tummy to do it, it's probably too challenging for you. If you're leaking or feeling downward pressure, it's probably too challenging for you. And from a diastasis perspective, I only care if it's a hard dome. I don't care about soft doming. Because soft doming, so the doming down the midline, soft doming is just taking up the slack. Whereas hard doming, we can clinically reason that, okay, you're maybe putting a bit of extra pressure on that tissue. I'm not convinced we will care about that once more research is done, because I feel like I get better results with people once I start loading them more and start stressing the tissue more. But for now, that's where we are. And I think when you don't have the research there, often it's better to be a bit more cautious. So a little soft dome that you can push into is okay. But if it's really hard dome, take it down and regress it slightly.
Just for anyone listening to this that's not sure exactly what we're talking about with this doming, if you think of the six-pack muscles, the line down the middle that divides them into 3 and 3, it's that line we're talking about. And when we're talking about doming, that area actually raises up and outwards.
And it's something that you will notice, and you get it in men, like you say, you get it in men and women. It can come with obesity as well. And you know, you might be a young fit woman who's not had a baby, and when you're doing a sit-up, you notice something pops out the middle, and you'll see it. It's like a very large outie the whole way up your tummy.
It looks like a Toblerone going down the middle.
Exactly.
Just, we've obviously discussed diastasis rectus and what it is and what it looks like. What are the consequences of it? Like, is there evidence to say it's linked to back pain?
I'm not sure. I'm not sure it matters that much.
That's it.
So, and that's the thing.
Just thinking as we were talking about it.
Does it even matter? So, in a way, there was some research done ages ago, and so I used to spout this out years ago about, it's linked to back pain, it's linked to and actually, in my clinical head, I'm like, if anything, it protects you against any pelvic floor issues, because if there is pressure, it's going to come out the tummy, not go down onto the pelvic floor. So, really, it's obviously we want a functioning abdominal wall, but with diastasis, I find I usually get people to a point where they're functional, i.e. they can do everything they want to do, they get back to everything, they physically are in a really good position. But some people might be in a position where they can do everything, but it just doesn't look that great. But sometimes the look will improve with the function. So we always have to focus on function first, but occasionally you do get people that just remain really unhappy with the look of it. And that's when you can look at, having surgery for that. And I have referred people for that, and that's, you shouldn't feel shame if you care about that and want to have something done. It's your body, and that's a decision, but it's not a small decision. An abdominoplasty is a major operation. It's a much bigger incision than a cesarean. It's a long recovery, and I haven't had many people that have had it done, but I've made sure they've spoken to people that have also had it done, and they know exactly what they're getting themselves in for and what support they need after. So it's not a quick fix, but I find most people get to a point where they're like, you know what, I can do everything. And it doesn't quite look as it used to be, but actually I don't really care that much anymore. But each to their own. And the focus is on function and tensing and strengthening.
So we've spoken kind of about getting back to exercise, and for a lot of people that means running.
Absolutely.
So when would you recommend getting back into running? Is there a particular way?
Yeah, so again, I'm like a broken record. There's not enough research, but there's no, but it's changing.
PhD in this for you somewhere.
Oh no. So there's no kind of international guidelines on when to return to running, and there's not loads and loads of literature. But fairly recently, it's been about a year, I think, a few colleagues of mine wrote some running guidelines where they did a literature review of all the current evidence and came up with a guideline, which is so useful, and I use it all the time. Immediately started using it in my practice, and it's just been brilliant.
And we can flag that in our notes so people
running.
It's really readable.
Yeah, exactly. It's brilliant. And
who are the authors on that? Sorry.
So it's Emma Brockwell, Grenier, I can't remember her surname, and Tom Gooms, who's an MSK running physio. So him and then the other two are pelvic health physios. So it's brilliant, and it went really viral, and it's really exciting, and because it was needed. So that's why it got so much attention. So again, I'm sure they will be updating it as more research is done, because we are starting to do more. But yeah, I think what they found in their research that really, not research, their kind of literature review, is that the earliest anyone should be considering running should be around the 12-week mark. And this is not, I don't want people to feel that we are restricting them in any way. Like, most physios now are very, we want people to get back to all the things they want to get back to. I don't want to restrict you. And it's not that you can't do anything, but just like you wouldn't go from doing no lifting to going to the gym and lifting the heaviest weight straight out, we don't want you to go from kind of what a lot of people do after birth is they walk, they do their pelvic floor exercises, brilliant, and then they may do some Pilates, brilliant, and then they think, oh, I'll go running now. And that in a way makes sense, but actually when you think about it, Pilates and pelvic floor exercises and walking haven't prepared you for running. So when we run, when we have impact, our pelvic floor contracts 400 times. So it's percent. So we can't, a voluntary pelvic floor contraction, get my words out, can't prepare us for impact. Yes. So the only way to prepare our pelvic floor for impact is by doing impact. Yes. And so we have to ensure, so if someone comes to see me at 6 weeks and their goal is to return to running, I'm immediately thinking, okay, let's ensure you've got your exercise program is incorporating graded impact, return to impact. So for example, that might be mountain climber sequence, because that's impact without gravity, or it might be just stomping a bit harder when you're walking. It might be then some standing things like squat jumps or lunge hops or hopping on the spot, or skipping and building up. So you're starting to get the pelvic floor prepared for it, and you're able to monitor what's going on. So if someone says, oh, I'm leaking a bit with my mountain climbers, we might want to look at the strategy. Okay, let's have a look at how you're doing it. Are you making sure you're breathing and you're not gripping, which is causing downward pressure? Let's, because if you're gripping your tummy, your pelvic floor's not bouncing and it can't absorb impact. So we might want to regress it a bit and build it back up. So again, it's finding that level, but we need to make sure there's an element of training for impact. And then from the 12-week mark, if everything's fine, in the running guidelines, there's some running tests that, again, you can do and give us a good idea that maybe you're ready or nearing ready to return to running. On the whole, though, people know when they're ready. And so if those running tests you kind of pass and everything feels good, we then recommend a program such as Couch to 5K, which sounds really slow and boring if you are a runner, but to be honest, you can skip ahead a bit if things feel fine, but usually it's been quite a while since you have run, and people quite enjoy the slow build up of it. So yes, I would say, it's not that everything's great by 6 weeks. It's more 4 to 6 months before all the tissues, the connective tissue and the pelvic floor and everything is recovered. So we have to look at the whole picture, but the earliest we say is 12 weeks. And as well as the preparing for impact, I would also be looking at single leg stability, because running is a single leg activity. Yeah. So if you're not really robust on one leg, generally the fallout is going to come to the vagina, because that's our weak spot.
And I think for Pilates, any kind of Pilates instructors listening as well, I say this a lot, I feel like probably some Pilates people hate me for this, but Pilates will not give you power, and the majority of what we do will not be impact. So no, jumping on the reformer does not count. It's not against gravity, it's less than body weight. So know what your speciality does. It can be amazing for that kind of reconnection and that breath work and that real control and stability, but it's not going to make you jump higher, and it's not going to make you run faster. So if you've got someone with those goals, that they want to get back to CrossFit, that they want to go for a run, that they want to do an Ironman, you have to refer out, whether that be to a strength and conditioner, whether it be someone like Reece, who's more of an S&C physio, PT, that sort of thing. You need to refer out, know what your modality does. And unfortunately, as much as I adore Pilates, it is not impact and power.
It's just on the continuum, isn't it, really?
It's part of a really beautiful
It's amazing process for the pelvic stability and general stability, which you also need, but you can't just miss out the preparing for impact. And some people can just return and they get lucky, but on a whole, you've got to build it up.
I mean, what you described just there in regards to the build up from basic through to basic pelvic floor through to strength exercises, through to more dynamic hopping,
Yeah.
more
Yeah.
force.
It's
Sounds
not
like any rehab program.
exactly
any rehab program.
It's exactly the
no
same.
different.
It's no
Yeah.
different. It's
Yeah.
no different.
Yeah.
What's lovely about doing an internal examination, which again I feel really privileged that I'm able to do these and women let me assess them, because it just gives a bit more information. So a lot of personal trainers refer into me because just for one session, because they've got their trainer, they've got their plan, but actually I often allow them to be less cautious, because if you don't know what's going on, you tend to be more cautious when you're rehabbing someone postpartum. Whereas if I've assessed them and I'm assessing internally and I'm thinking, actually your pelvic floor is really good, it's nice and strong, it's nice and flexible, it's traveling through good range, it's really well coordinated with the breath, you don't have a prolapse, and also you're low risk for prolapse. So we take measures often in physio where we measure the genital hiatus and the perineal body length, and there's some research that's shown that if they fall less than 7 centimeters for that, they're low risk for prolapse. So if I've got someone and I'm assessing them and I'm like, great, then actually I can go back to the trainer and say, crack on, they can lift heavier, you can do a bit more with this person. Whereas if I'm assessing someone and I think, you know what, there's some mild prolapsing and your pelvic floor's a bit weak, it's like, we'll get there, but actually let's do a bit more of the building up and let's spend a bit more time on that. So it just allows you to be a bit more bespoke, really.
And one of the things I love about when we refer to Clare is that internal doesn't just have to be lying down.
Well, no, it shouldn't be. And not to say that sometimes like I said, in a busy clinic and you might get caught up with something else, so you only have time to do something in lying, that's fine. But ultimately, if someone is wanting to be really sporty and active, we've got to assess them in standing. And it's a bit awkward, but I mean, especially if you're assessing prolapse, a prolapse is gravity dependent. So you need them standing up. And if someone wants to get back to CrossFit, lifting weights, impact, I mean, we do it all. We bring the weights in and I just sit on the floor and we just do the examination with movement, with function, because I want to check you're not bearing down. And if I've checked all these movements and you're not bearing down with it, then you're good to go. If you are bearing down, we need to practice changing that. So yes, I think most physios now are much better at assessing functionally, i.e. in standing, with squats, with lunges, with lifting, and things like that.
We've spoken a bit, and you've mentioned a number of times about an internal exam.
Yes.
For people who are wondering,
Yes.
what happens in an internal exam?
Yes. So it's often people feel quite a lot. To be honest, once someone's had a baby, I've barely even had to do the spiel and they've already undressed and lying on the plane. They're just so used to it. But before, people think, you want what? Do you want me to take my knickers off? So obviously we make sure, physios, we do like to chat and we're really good at explaining exactly what everything involves. And a lot of women have had smear tests and things, but it's not like that. So basically, it's a vaginal examination. We don't use the speculums like you have with a smear test. So it's gloves with one finger inserted into the vagina. Normally we look from the outside first. So we might have a feel around the superficial pelvic floor muscles. We will have a look at the kind of structure, and we'll get someone to push down, kind of bear down as if they're doing a poo, and we will have a look at their organ support. So is the bladder, the womb or the bowel coming down with that? And is there a bit of a prolapse going on, or is it really well supported? And then I normally ask them to do a pelvic floor contraction, and I'll have a look from the outside, because if it's strong, you can see the perineum lift from the outside. And then we'll check internally. And like I said, it's one finger. It should not be painful. It should not be. I think it just shouldn't be. I know people will have had painful smear tests potentially in the past. I have, but it shouldn't be painful. So if it is, you need to be saying something. So we come onto the side wall of the pelvic floor and we'll ask you to squeeze your pelvic floor. So when you're squeezing your pelvic floor, we know from the research that you do tend to get a more optimal squeeze when you start at the back. So I tend to say to people kind of imagine you're stopping wind or something like that. So you're closing around the back passage, and I will feel a contraction internally, and I will be able to grade it out of 5. But it's not all about strength. So I have many patients with a 5 out of 5 strength pelvic floor who are still having issues with leakage and things like that, because it's not all about strength. So we'll grade your muscles, and I'll also check that they're traveling through full excursion. So like we said before, being strong and being flexible, just like you strengthen any other muscle. It's no different. But is it traveling through full range, or is there some tension and restrictions within the muscle that we need to treat and address? And what's the coordination like? So as we spoke about before, the connection between the breath and the pelvic floor and the glottis and the pelvic floor is huge. And we know that as we take a deep breath in, the diaphragm will drop, and that will cause a downward pressure onto your internal organs and a downward pressure onto your pelvic floor, and that will allow your pelvic floor to lengthen. And as you breathe out, the diaphragm will recoil back up, and this will cause a pulling up of the pelvic floor. So as you breathe in, everything drops, and as you breathe out, it comes up again. So it's this nice bouncy unison that's going on. So we want to check that there's a coordination there. So I get some women who are leaking purely because they can't coordinate it and they can't connect it. And actually the individual muscle is working perfectly well, but it's not working as a team. So we'll look at that, and again, feel around gently. Is there any tension points? Because like I said before, it's quite common to find that for some women, the weakness is due to holding of their muscles and tension. And that's it. And for some women, we will do an anal rectal examination. So definitely if you've had a 3rd or 4th degree tear, or if you're getting a lot of symptoms from the back. But you can obviously decline that, and we can get a lot from our examination from the vaginal examination. So yes, if you've had a tear into the back passage, we would advise that. But it's all discussed, and it's not as bad as it sounds.
I think it's important for people to know that, because on face value, it sounds quite invasive in a way. But when you then explain it the way you just have, it's all very guided and
slow. Yeah.
So, and as we've discussed over these 4 episodes, like, super important as well to have that knowledge, because it's just linked to so many different things. Yeah,
well, they're the muscles that support our organs, keep us dry and help with continence. They're really important for our sexual function, because you've got the superficial pelvic floors that merge with the clitoris. So it's really important for, sexual enjoyment and strength of orgasm. There's research around all of this. And obviously it's the base of your core. So important from a kind of general pelvic stability point of view as well. So yeah, they are really important. And so starting your pelvic floor exercises as soon as you can post-birth is kind of the number one thing to do, but also making sure that the muscles are fully letting go, and the letting go is just as important as the lift, and also varying the position that you're doing the exercises in, so it's not all in lying, because if you're only exercising a muscle in lying, you're only preparing it to work in lying. So again, it's the same as any muscle. Sit, stand, and eventually you want to be doing kind of 8 to 10 quick squeezes and maybe 10 holds, trying to hold for 10 seconds in a standing position, ideally 3 times a day to build strength. So it's a commitment, but there's so much evidence for them, and the sooner you start and develop that into your routine, and they're kind of the non-negotiable that we just want happening in the background. And then on top of that, we'll look at the graded impact and the single leg stability and balance work and more specific exercises. But as a basis, we want those pelvic floor exercises kind of going on
super important
every day.
Just as a bit of a side note, I managed to find that document that Claire
that's
was talking about. So it's called Return to Running Postnatal, Guidelines for Medical Health and Fitness Professionals Managing This Population. And it's by Goom, Donnelly and Brockwell, 2019. I'll put a link to that in the show notes and things as well, so you can easily access that.
So before, we've obviously spoken about things that you will immediately see, something like a diastasis, but if you've had a C-section or something, so what happens after that? What can you do? Obviously you get told things like don't lift your baby and things like that. So is there any kind of tips you can give people for C-sections? Where are those myths and that sort of thing?
Yeah, so with a cesarean birth, with any birth, straight after having a vaginal birth or an abdominal birth, you don't want to be doing loads of really, really heavy lifting. Of course you don't. It's like if you really badly sprained your ankle, do you go for a run every day after it? No, you've got to let the tissues heal. And there is definitely an element of just don't do that much for the first few weeks. And that is actually going to get you back to things quicker. So, I had a lady fairly recently message me in a massive panic because she felt very heavy and she felt she might have a prolapse or something like that. And
when you say heavy, you mean
in her perineum, in her vagina, like a dragging sensation, which is what a prolapse would feel, a heavy dragging feeling. and she was really stressed about it, and poor her and all the rest of it. But then we realised after a while she'd only had her baby 5 days ago, and she'd been walking hours a day with the baby in a sling, because she's like, I want to be walking, and I know that's important for me, and of course walking's important, but also all your pelvic ligaments have been stretched, and just be around your bed for 5 days. No, I think there's definitely an element of I think if I had a baby, the first couple of weeks, I'm just not going to go much further than my bedroom. I'm just not. And then I'll build it up gradually, because there is that just initial healing. And again, same with the cesarean. So I think often people think, the cesarean, it's much harder initially and you're restricted. But I think whatever delivery you've had, you don't want to be doing lots of heavy lifting immediately, but of course you can lift your baby. And so often it's not it's not what you do, it's how you do something that's important. And you can generate more internal pressure down by picking up a bit of post from the floor if you're doing it by using a strategy where, for example, you brace and breath hold, which a lot of people do. A lot of people, I catch people just opening a fridge and they kind of brace their tummy and breath hold, or you see people getting off a low sofa and they'll hold their breath to get up. And a lot of us use this high load strategy for low load tasks. So it's how you're lifting that's important. So if you're reaching over in bed to lift your baby to feed, you're not kind of holding your breath to lift the baby. You're making sure that you're breathing whilst you're lifting. So some people find in the initial phases blowing out helps them get into that routine. So, there's no one way to breathe and one way to lift, but essentially just making sure that you are, and making sure that you are breathing means you'll manage the pressure. Because if you're breath holding and bracing, the pressure is going to go down. So, and with a cesarean, I think you are going to probably want to do some scar massage, around the area and the whole lower tummy, so from the belly button down, not just the scar, actually just getting the tissue. You want to desensitize the tissues. Scar tissue itself isn't a problem, it's not painful, and we all have it, but actually you want to get the tissues mobilized a bit. You can't strengthen what's stuck, and you can't strengthen what you're disconnected to. So just kind of doing a bit of massage around that area to desensitize the tissues, get them used to being touched again. Because essentially it's as far as your brain's concerned, there's been an attack to the body there. So we need to desensitize that area, get the tissues moving. And there is some evidence for silicone gel. I probably would. A lot of consultants prescribe silicone strips. But you can get silicone gel for £20, and there's a bit of evidence for it. So why not put that on as well? But yes, I think if you find that you have a prolapse after birth, I think it's really important that, a bit like you were saying earlier, Reece, you frame it as an injury. Whereas because of the language around prolapse, so many people, and it makes me really upset because so many people feel extremely distressed by their prolapse. They think it's the worst thing in the world. They feel shame that they have a prolapse, and it just becomes they might go online onto Google and hear that, okay, I mustn't lift anything and I mustn't ever run, and they feel extremely restricted and that they can't do anything and that their life is over, and it becomes this, and I'm not exaggerating, people become their prolapse, it becomes this awful thing. And it's our fault as health professionals for making people feel that, and we need to reframe it. You would never, my boyfriend recently had a bilateral medial collateral ligament ruptures. He didn't come home from getting that MRI thinking, oh my God, my life is over. This is the worst thing in the world. It's just a bit like, okay, I probably should do some rehab for that. I'll go and see the physio and they'll strengthen me up, So if you've got a prolapse and you've got a bit of laxity in some of your side vaginal walls, we just need to strengthen you. We need to build you up. And it's not a case of just thinking, oh, it doesn't matter, I can do everything. But it's also not a case of doing nothing. We've got to find that sweet spot and that level that will work for you. So yeah, try not to go on forums if you've had a diagnosis like that, and
listen to this podcast.
And take control. There's so much you can do, and these things are treatable. And even some of the best consultants and the best surgeons in urogynecology, who I refer to because they're fantastic surgically, they don't rehab patients, and so they will still tell my clients that they can't lift. And we now know, finally, there's research coming out that shows that lifting is reducing in the right way, can reduce your prolapse symptoms. So just like anything else. So yeah, if you're lifting something and you're bearing down and it's feeling heavy, that's going to weaken the pelvic floor. But if you're finding the level that works for you and you're feeling good with it, that's going to start to strengthen it and build you back up again. So yeah, doing nothing and not lifting anything and not moving is not going to get you anywhere. So yeah, seek some support and some guidance on finding the right level for you.
Just one thing I really want to cross off, and I told you guys this story offline before, but I had a real epiphany moment in a class I was teaching a few years back, and it was 4 women, all probably late 40s, maybe even in their 50s, and one of them mentioned about leakage during exercise, and the other 3 in the class all went, yeah, and I was sitting there listening to this, thinking, and I said to them, I'm like, there's things that can be done about this. Like, it doesn't have to be a normal thing. So I guess, Claire, just your thoughts on even 30 years down the track, I think incontinence and other things can still be helped.
Yes, I did an article recently in the Telegraph, which is amazing. But I've, off the back of that, had so many women in their 60s, 70s, 80s contacting me, just like, oh my gosh, I can't believe there is something I can do about this. I had no idea. And, I think, of course there are times when we can't get someone 100%, but people always improve, and then it might be that you get to a point where you're almost there, but you're not quite. I'm not saying everything can completely be resolved with physio. That's why there are the place for medication. There is a place for surgery, of course. But absolutely, there is so much we can do. And it's never too late. Same with diastasis. I think a lot of people think I've got to act on it now. Time since delivery is irrelevant. Obviously, the sooner you start, the sooner you get things sorted, and the better, because it does start to affect your quality of life. There's some stats actually that show if you have urinary incontinence in the first 6 weeks post-birth, you are, I can't remember the percentage, but you're something like 60% more likely to have postnatal depression. It's really high. Okay. So, we think these things don't affect us, but it does get you down a little bit. It doubles your risk. Of getting postnatal depression if you're leaking afterwards. And yes, there's so much we can do, whether or not it's pelvic floor training, whether or not it's bladder retraining, fluid advice, advice on emptying your bowels. It's huge. So, and I think even just being able to speak to someone and start along that process, people feel so much better.
Sure.
And in terms of incontinence and prolapse, is that always immediate? Can you get it later as you start to train and you start to do more? Like, what signs and symptoms should you look out for?
Yeah, so no, it might not be immediate because, again, initially after having a baby, you're not necessarily challenging your system. So you might think, oh, everything's great. And then you start your return to running or your return to HIIT classes and you might be totally fine, but then you go to do a star jump and you think, So star jump's quite a common one because the legs are apart, it's quite vulnerable, and the impact with your legs apart. I mean, the stats for athletes are huge. I mean, a lot of trampolinists and gymnasts, it's because it's a big hit on the system, and so if you're getting that, don't panic, but don't just ignore it. We can train that, and it's just too hard for your demand. So if you're noticing these symptoms,
so what would those symptoms be if you just sum them up for us?
So with any symptoms?
Yeah, for like leaking. And,
so
for incontinence and prolapses.
Yeah, so with bladder, it's pretty obvious because you would feel the leakage. Or you may feel bladder urgency. So you might just feel really urgent and that you need to go to the loo when you're exercising. With prolapse, it varies, but it tends to feel like a heaviness or a dragging inside the vagina, almost like there's a tampon inside that's coming out, but there isn't. So some people feel more of a bulge. Some people won't feel heaviness, but they will notice when they go to the loo or something that something is there. What's important with prolapse is that it's not harmful, it's not bad for your health, really. So it isn't something to panic about. You may notice that you can't fully empty your bladder or fully empty your bowel. So you go and you feel like there's more there. So yeah, incomplete emptying. You may be going to the loo much more frequently. So these would be the signs that something is not quite right. Yeah.
Beautiful. All right. We've well and truly gone over our normal 30 minutes, but there's some really, really valuable information in there. Certainly, as with all of these podcasts that we record, I've certainly learnt a lot today.
And hopefully we'll get Claire back and talk about all things menopause and athletes and everything else. We're going to try and convince her to come back again.
Absolutely. Hopefully she'll indulge us and come back again. Excellent. So Claire, thank you so much for sitting down with us today. As I said, I've learnt a lot, and I hope people listening to this learn a lot from it as well. I think there's some super valuable information in there. So just once again, anyone that wants to get in touch with you, what's the best way?
Yes, so if you've got any questions or you want to book an appointment or anything at all, you can email me at Clare, CLARE, at rephysio, so it's rephysio.com, or follow me on my social media, which I'm not very good at updating because I'm always in clinic, but occasionally I put a little bit of information out there on re.physio, so re.physio on Instagram.
Excellent. Okay, so that wraps up episode
Awesome.
4 with Claire, which is episode number 10 for us. Exciting, we've hit double figures.
Hopefully people are listening.
Excellent. We'll be back in the next couple of weeks. We've got a couple of really exciting guests coming up, actually, which I'm looking forward to. If you want to see us, we also have opened up a Instagram account as well, which is Complete Health Podcast is the handle, all one word, no gaps or anything. So we'll be updating information. We'll be putting some of the show notes and links and things on there as well. So keep an eye on that. Anything else to add, Helen?
If you already follow the Pilates side on complete_Pilates on Instagram, I will double up and reshare all that stuff as well, so you can kind of get a second hit of it.
Fantastic. All right. Thanks again, Claire. Thanks, Helen.
Thanks, guys.
Excellent. And we'll see you all again soon.
Bye.
That concludes episode 10 of the Complete Health Podcast. For any information or questions, please feel free to email us at either reece@complete-physio.co.uk or helen@complete-pilates.co.uk. We're also on Instagram as @CompleteHealthPodcast, all one word.
If you haven't already, please go back and have a look at our previous episodes with Claire, where we discuss what exactly pelvic health physiotherapy is, common pregnancy-related musculoskeletal conditions, and the options you may be presented with during labour. Keep an eye out in coming weeks for our next guest, Dan Boyd, where we talk about all things related to bike fits and triathlon. For another week, stay healthy and goodbye.